I'd now like to introduce Scott Johnson, who's the director with Hancock, Daniel, Johnson & Nagel, PC, a law firm here in Richmond. His emphasis is, practice emphasis is on governmental relations at the Virginia General Assembly, representation of healthcare providers before Virginia's health regulatory boards, and matters before the State Corporation Commission. Mr. Johnson serves as general counsel to the Medical Society of Virginia, the Virginia Dental Association, and the Medical Society of Northern Virginia. So please join me in welcoming Mr. Johnson.
Well, I tell you what, I sure am relieved at that nice introduction that Joe gave me, because when Carol Sale called me to speak, she left me a voicemail and she said, "Scott, we need a sorry lawyer and you're the sorriest one we know." And I said, "Well, you know, I resemble that." And she says, "No, seriously, we've got a great panel of speakers. We've got a lot of professionals. We're looking for a little cultural diversity. And we thought of you because we need a redneck lawyer that lives in the country that drives a pickup truck." And I said, "That's me. I can do that." But seriously, I'm glad to be with you all today. And let me get my pointer here as we move ahead and talk a little bit about some things. Let me just give you a roadmap of what I wanted to touch on so you can know where we're headed and know where we're going. Don't want to spend a whole lot of time talking about what all the laws are, because that's boring stuff. Let's talk about where we are in Virginia, where we are on the cutting edge, the next steps. That's going to be the big focus of what I'm going to look at today. So with that type of background, a moment on history. You know, as we look at disclosure, as we look at I'm sorry, much of that was born out of the process of saying we've got to learn from our mistakes. If we learn from our mistakes, hopefully we won't repeat them. But initially there was a great fear of, if I say too much, I will be sued. And I challenge you with this. Have those fears begin to diminish a little bit? Are things changing? You know, initially the number of lawsuits against physicians had continued to grow, but I bring you hopefully some good news. From the Board of Medicine statistics in 2007, there were approximately 222 settlements or judgments. And keep in mind, there are about roughly 18,000 licensed physicians practicing in Virginia. That number dropped in 2008 to 153. I would suggest to you somebody's doing something good, but a correlation that we're seeing is a burning desire now to say it's time to actively participate in disclosure. It's time to advance the ball as best we can. So what are the incentives out there? Where do we go from that? One of the things that I would suggest to you is we need to learn from our opposition. And our good friends, the trial lawyers, if they were here today, they would tell you that the vast majority of the patients that walk in their doors to hire them to sue a healthcare provider will oftentimes say one of these following things. Nobody would talk to me. Nobody would answer my questions. I couldn't get information. If they'd only agreed to meet with me. I'm here not for me, but I'm here to make sure that whatever happened to me doesn't happen to that patient next week. So how can we regain that trust? How can we build that confidence? How can we go from there? You know, we talk a lot about creating a culture of transparency. That word is getting mighty old on me. I would suggest to you maybe we ought to approach it by creating a culture of truth. My dad has a saying, and he's my best expert. He tells me if you tell the truth, you don't have to worry about what you've told. So whether you call it transparency or whether you call it truth, I think that's what we need. We don't want to be associated as an industry, as a core provision of service providers, associated with the Enrons and the AIGs. I would ask you this, are we at cliff's edge, or are we already to the point that we're in free fall? I look around here and I'm glad to see that there are plenty of people in the room that subscribe to the old comedy on Saturday morning, the cartoon Bugs Bunny. Are we Wile E. Coyote half the way down with the big eyes and the big look, or are we teetering on the top? Where do we go from there? There are a number of different laws out there, and I don't want to bore you with them, but I would just subscribe to you one thing for states that have taken that initiative. In December of last year, 2008, The Office of Inspector General issued an excellent report that's available online that basically traces all the adverse reporting requirements that are in place by the various states. And you see there that everybody does something different. Some says the disclosure is required, some states are silent, some states say it has to be in writing. I only ask you this, is Virginia going to be one of the next states to try to step out in that realm with the General Assembly? Are they going to feel pressure to answer back to their constituents? We are in an election year, we're not here to talk politics, but with 100 delegates up for election out talking to their constituents, your patients, they're hearing information and they're hearing requests. And will we see similar efforts going forward? We need to be mindful of that. A couple of different approaches here. Of those states who have spoken, notice on the screen how some states want to take the approach of accountability, meaning you've got to do this because we want to hold you accountable, and that's how we'll force better health care. Other states take the approach of no, it needs to be learning. It started as a learning process. Any disclosure efforts need to be in that arena. I submit to you it's going to be very interesting to track the success of those two approaches. Will accountability truly work, or is it going to be something that we get better results if we keep it in a learning module? Can't just look to state law. We've got to look broader than that at associations that have spoken. The AMA has the policy position you see up there on the screen, and I emphasize that last portion of it as a guiding principle. You may have seen that in some of your other works, but a desire, a request ethically for physicians to convey that information. Hospitals are not silent on it either. The Joint Commission has told you that sentinel events have to be informed to patients or patients' families. The next screen is the one that I get the most comment on. And that is, of our licensed physicians, many of them are great clinicians, but many of them face challenges to keep up with all the requirements at the Board of Medicine. And this is one of the regulations that we oftentimes remind them of, that at the end of the day, if you're weighing what to do, not only look to the law, not only look to your national association, but look to what the Board of Medicine has said currently is required of you to help you navigate your path. I have found that to be a very motivating factor when they see that. When they learn of that, they feel, I've got to honor that. That's where we need to go. I had an interesting thing. I am a reformed medical malpractice defense attorney. I retired from that in August of 2006, and one of the cases that I defended prior to that involved a patient who worked in a law firm, a very knowledgeable person, a person who was very, very upset at the lack of disclosure, at the lack of information. When this presentation got posted on the VBCH website, this patient emailed me. She said, I see you're speaking, I hope you remember me. Let me tell you what I hope you say. Now, what fool is going to stand up in front of you today and not say what this patient said? That's the best evidence off the street. So this is directly from the patient. This came from her email to me. She was very, very upset. She felt she had been lied to. And we all hate that, and we all know that lying is going to promote anger, and she had plenty of that, as she probably should have. Blocking access to records was something that bothered her. Now you're all thinking, well gosh, our medical records department, they know what they need to do, they know how they need to act. That's probably true, but sometimes situations when you've got a records request, they fall through the cracks. Not everything got copied, it's a day or two late, it's sort of the snowball effect. And that's what this person had. Again, she's telling us, as you look at disclosure, be mindful of those red flags. This one was an interesting one. That patient brings their own personal history there. Sort of goes back to the art of listening. There's nothing better that we can do but look at our schedules. Look how hectic you are, how many people today have been consumed with Blackberries and cell phone calls this morning, how there's really not a lot of time to focus. But listening to that patient often lets them convey to you key information, convey to your nurses, convey to your doctors, but oftentimes the art of listening is foregone. I liked her last point here. When I used to be a defense attorney, that's what we would tell the physicians or the nurses that we were defending. They're very comfortable talking to patients, but they're scared to death to talk to those 7 jurors that are sitting there in the jury box. So we would always tell the physician or tell the nurse, look at the jurors like your patient. If you're really upset, if you're really nervous, if you can't control your emotions, imagine all of them are sitting there in their underwear. That seemed to calm them down a little bit too. But notice that this patient is telling us, look at me as a face of one of your loved ones. In other words, make sure when you look at that patient or treat that patient, you would do so as it were your spouse. I thought maybe of all of this today, having that perspective driven home could be one of the more important things I could bring to you. Well, let's take a little different turn in the road and talk about hospital disclosure policies and some work I've done with that. I've had the fortune of working with some medical staffs that have tackled hospital disclosure policies, and we've come a pretty good ways over time. You know, the initial pioneers in this arena often involved situations where you had hospitals working with employed physicians, so everybody had all of the same insurance, everybody seemed to be all on the same team. But it didn't take long to realize that as work on disclosure seemed to push ahead, we also had the issue of medical staffs comprised of physicians in independent practice. And there was a pause that needed to take place. How were we going to bring everybody to the table to get a commitment? You had defense attorneys saying to physicians, if something goes south, shut up, call me, don't talk to anyone. How do you balance that against the statutory, ethical, regulatory obligations that we looked at a minute ago? So let's look at some recommended steps, what seem to have worked so far to share with you. Number one, the defense attorneys, the physicians on medical staffs would first say, I want to call my professional liability insurance carrier. I want to see what they have to say about early disclosure. I don't want to do anything or say anything that may be an admission against liability. I don't want to do anything or say anything that may jeopardize my insurance coverage. And fortunately, many of our professional liability insurance carriers in the state have very aggressively put in place sort of emergency response teams to answer physicians' inquiries and to deal with this, to help navigate the disclosure issues. Those resources are out there, so recommendation number one to you would be, if you're going to tackle this, try to make sure you involve them. They are very good resources, and if they have a seat at the table, I submit to you the physician or provider they insure will also have a greater seat. That middle portion up there on the screen is probably one that is the best to try to avoid. Avoid the idea that administration is here to help you. Administration is here to give you a new idea. Administration is here to tell you what we're going to do. Physicians do not like being told what to do, according to what I've heard. Lawyers really hate that, but that comes into place there. But medical staffs need to make sure that they feel like they have a say, that they have an impartial way to get advice and to be guided, and that this truly is a collaborative decision. The last piece on the screen I would mention to you is this. Disclosure, reporting adverse events, is not a stagnant process. It's not something that we can say we'll have a policy today, we'll never deal with it again. It evolves, it changes, and it is something that if you invest the time to create the first one, I submit to you, invest the time to have periodic updates, periodic reviews, find out how you can hone it, look at what other states have done in order to do that. Another thing that is very interesting in this process is, as we have seen medical staffs that have physicians in independent practice work with medical executive committees of hospitals and hospital administration, one of the things that seems to answer a lot of questions, and mainly the question is, will this disclosure policy hang me out? In other words, will the hospital disclose something that will make the physician the fall guy, and as a result of that, I'm going to be in worse shape? And sitting down with some basic education about how the medical malpractice system works, how settlements work, how if the hospital were to settle, the physician, if sued, would get credit for that if there's any jury verdict that's brought back. That seems to bring some comfort. So I would submit to you just some basic education on that has seemed to work very well as we've gone forward. I borrowed a piece from the Prince William policy, and we're fortunate. I think our state is one of the premier leaders. Prince William and Centra Healthcare, through the work of many up there, including Dr. Carey, the president-elect of the Medical Society, have been very aggressive in trying to plow the cutting edge, and I commend that. One of the things I thought Prince William did well was trying to make sure that this is a proactive, because one of the things that patients tell us is they think hospitals in the brick and mortar are cloaked with secrecy. And any effort to have a policy of how you're going to interact is going to be viewed with suspicion, viewed as suspect, and so the more proactive it can be, the greater the comfort that we can be. One of the things that has been the biggest challenge throughout this whole policy or whole process has been making sure we have got clear definitions, clear terms. It's not enough to mention a term in your policy because it may be defined 3 or 4 different ways through other sources. You know, lawyers, we like to tinker with words, and that has been one of the things that there's been a lot of tinkering in all candor. Healthcare lawyers have struggled to make sure that everybody's got a clear understanding of what the words are. I submit to you that procedural steps should be included in your policy, because the worst thing you've got to prepare for is Friday night, being the first Friday of the month, full moon being out. At midnight, the person that will get the call may often be the person least prepared to handle the crisis, and that is the junior most person on the administrative team, or the situation where all of the physicians that have the cool approach, the level-headedness, the calmness, are not available to come respond. And so whoever is called into that situation very much needs a cookie-cutter approach, if nothing else for consistency, if nothing else for protection of them, if nothing else to make sure that disclosure happens and the patients and their families get told what they need to told. Some will always question, do I really have to do this? You know, physicians have been trained by the lawyers they hang around with. There's always got to be an exception, and so can't I find some way out of this? And again, you would do yourself service in your policies to always navigate and spell out what is an exception, will there be any exceptions? This again will avoid hopefully some confusion. Well, let's talk about what has happened on the legislative front. Dr. O'Bannon, I saw him here earlier today. He introduced HJR 101 in 2008 that sort of got Virginia on a formal discussion of this issue. And you see there on the screen that his directive was for the Joint Commission on Healthcare to look at a broad plethora of issues, look at apologies, look at disclosure, look at early mediation, which we'll talk about in a few more seconds, because he thought our system can be improved here as we go forward. A very broad charge. Now, the General Assembly didn't pass the legislation because there was an agreement that the Joint Commission would undertake this study on their own, and they have. And I don't know if Jamie is here today, but I cannot applaud her work enough. It is yeoman's work to go out for a commission of this nature and be asked to gather across the country all the journal articles, all the statutes, all the law reviews, everything you can, and come back and try to help navigate us. But you see the website there for the Joint Commission. You will find a report there that is done, very straightforward, easy read, but she has done an excellent job on that. She had some pretty wily characters to have to deal with, because in addition to Jeannie Franklin on behalf of the Bar Association and Pat Devine trying to organize this group, you see the various organizations that were represented up there. And anytime you get this many groups in the room, you certainly are going to have 1 or 2 opinions, and it's shocking they may not all agree. But we started in 2008 trying to tackle this and go forward. And one of the things was do all of this work and come back and recommend to the Joint Commission what course we should take and what we should do. You see some of the focus objectives there that we were looking at. One I don't think we can pass without pausing a second on, and that is increase patient and provider satisfaction. Think about how much the practice of medicine, how much the practice of nursing, how much the practice of risk management today is not as enjoyable as it was 15, 20 years ago. Can advances in disclosure, can advances in this area help restore some of that satisfaction? You know, we'll never get paid enough, there will never be enough reimbursements, there will never be too few lawsuits. I'm wondering if this area may be something to regain that. Certainly, too, the next point you see up there is economics. One of the things that we face now is such a shortfall in healthcare funding. How much role can this play in truly driving savings? And if it can we measure that? What is the price of defensive medicine as we go forward. Patient trust we commented on, so I'll move to the next one. So we had the component issues that we looked at, and we wrestled with definitions. I'll say something about that in a second. But we were trying to figure out what is the best way to build this mousetrap. We did not have an easy answer. There was not one state who has done it perfectly that we would like to copycat. Everybody's had a different approach. Everybody's had a little different level. We were trying to struggle through that. We spent more time on these definitions up here on the screen than you can imagine, because for most of these terms up here, they are defined differently by different organizations. And one of the cruxes that we had as we started out in these discussions was trying to figure out, when are you going to disclose? What are you going to disclose? And if these terms have got to be defined in a way so you know what you're doing, we got to start here. But if we can't reach agreement on what these terms mean, or the definitions of them mean, or the right term to use out of the list you see up there, how are we going to go down this road? We asked that question. When I get an answer, I'll be glad to come back and share it with you. We don't know. We're still working on it. That very much is a work in process. We even spent a lot of time on two other key terms that you hear all the time, and that is disclosure and apology. What is really a disclosure, and what really is an apology? Because if we don't spell that out, again, as I told you, lawyers love words. They will nitpick that, and we'll be in a bind. So the charge was, let's try to gather as much data as we can and use that resource to build our answer. And I will tell you that we have got a tremendous amount. It continues to come in, and I would say that this study is really given us a leg up to go forward. But you can't have an unwieldy discussion. You've got to have a game plan. So we decided to try to break things up and say, let's look at them in compartments. Let's look at them in buckets, if you will, and let's try to figure out what our elements are going to be. We know we need something in a system to make sure we have early disclosure of an event so it can be looked into. And with that, how are we going to do it? How will that then mesh with what type of disclosure we're going to have to a patient or their family, and make sure there's not a conflict? And more importantly, how are we going to have some post-disclosure and follow-up? Back to my example about a patient. If a plaintiff attorney was standing here today, one of those things a patient would also say relative to communication is, immediately after it happened, I got a call and they told me that somebody at administration would call me back, and I didn't hear anything. Or I was told I would get some follow-up, but they didn't tell me when. Part of this process has got to be clear expectations. Who's going to call? When are they going to call? What are you going to be told as we go forward? Now, no one likes to talk without there being some type of understanding as to what's going to be repeated to you in a medical malpractice trial at some point down the line. In other words, what's going to be protected and what's not going to be protected. And 2 points at this issue came to a situation of how we're going to determine what's privileged. Looking at those compartments, how we're going to go through that. We even broached the idea, does Virginia need a new statute to say we're going to protect disclosures to patients and family completely separate from all the other privilege statutes that we have out there on the books. You can imagine that our friends at trial lawyers didn't think a whole lot of that idea, but it was one that was on the drawing board. The other thing we looked at was the real world. Everybody's motivated by something. Some say money, some say doing the right thing. And one of the motivating factors we identified is providers will be willing to participate in this process if you can construct the appropriate protections. And we've got to deviate just a little bit to talk about Johnson versus Riverside. Not sure if you know or not, but there are discussions underway between the trial lawyers, the Hospital Association, and the Medical Society to try to sit down and see if anything can be done to restore the protections to risk management that were eviscerated by that decision. That decision coming to us before our discussion started on HJR 101 has really been a cloud that has hung over it. I would submit to you, I don't know if you can work out a true early mediation disclosure process unless we're clear on what's going to be protected and what's not, but I'm very optimistic we can find a solution through this work group. One of the other things we identified was that early mediation is a key thing, a valuable thing. Now, what do I mean by that? Traditionally now, something goes wrong, you've got 2 years to file a lawsuit, at least another year before you get to court, And if there's going to be any mediation in a case, it's generally going to happen between 45 days and 30 days before trial, because each side wants to see each other's experts, each side wants to take a bazillion depositions, each side wants to get every medical record of every, toenail cut, whatever it may be that that person has had, so all the information is known. But what would happen if we had a system in place that parties could avail themselves to, where mediation takes place early, before suit, where mediation takes place as soon as the lawsuit is filed? Now, clearly all of that is permissible today, but I would submit to you having a structured system in place may help incentivize that. One of the other things we looked at in our discussions was, should there be clear evidence out there that Virginia needs mandatory disclosure? I told you a minute ago about a few states that require mandatory disclosure. Virginia is not there. The discussion the group had was saying no, that's not something that should be there. Another issue came up was whether we should take an approach of a voluntary approach versus a mandatory. And I mentioned to you a second ago, lawyers hate being told what to do more than anybody. And our friends, the plaintiff's attorney, says, look, mediation in Virginia has been and is very, very successful because it's voluntary. The lawyers decide when it works and when we need to do it with the client, and it's not something that's forced upon us. We live under the shadow of what's going on in Maryland. Maryland has mandatory arbitration. That's a fancy word for meaning that a retired judge is interested in sitting as an arbiter, and experience dictates that that judge calls in the parties and says, well, I guess if you could have settled this case, you would have. Anything you need from me, good day, I'm on the way to lunch. So you wasted expense, wasted defense costs, wasted time. The trial lawyers have told us very, very clearly they do not want anything as far as a mandatory mediation process. So from all of these discussions came our 21-page report that I mentioned to you online, and we had some recommendations to go forward. What's our charge? It's amazing when you look at something as complex as this issue, it boils down to finding the right definitions. Somewhat scary, but that's the basics. That's where we've got to go. The other thing we thought important is we can't stop gathering data about what other states are doing, because there are a lot of brilliant minds in this process. So that will continue, and Jamie will continue to compile that for us. But one of the other things that has changed in the landscape since we've been in is that last piece on the slide, and that is the federal level. We used to always think, don't worry about what happens in Washington, it will take 2 years or nothing may happen and they'll introduce a bill. We're seeing a Congress and we're seeing a president that are not either one going to sit on their heels, that things are happening. So part of our discussion now has to be focused on the federal level. What's going to happen there and how's that going to impact what is done here? We hope to come back and tell you that there is a model that can be crafted so hospital systems and health systems can put this in place in Virginia. We believe consistency would be good, again, not to mandate that anybody does it. And we're trying to figure out ways to continue to build incentives for this to be used. We have got a lot more work to do. It's not the end of the road, but a work in process. And I applaud all of you out here that have contributed to that already. The thinking was going into the 2009 General Assembly session is that this work group wasn't going to come back and have to tell the General Assembly, here's the course we want to take, because we weren't ready. But one thing that drove into prime time was the debate on the medical malpractice cap. And in that process, or from that process, came the introduction of House Bill 2057 by Delegate Hamilton. The Medical Society, in preparing for the medical malpractice cap, had engaged an expert that had come back and says, as I look at Virginia's I'm sorry statute, which we passed in 2005, the statute does not appear as broadly as does the statute in some other states. So I believe that it would be in the best interest of providers to try to expand that because I see benefit coming from that. So if an expert says we need to do that, it makes sense, it's reasonable, you've got to take that advice and advance it. So the decision was made to impact or introduce this legislation to favorably impact claims frequency and severity. 36 states have these statutes in place, and if you remember, Virginia was on the cutting edge that was followed by many states. Notice the distinction here. We're in the larger group that basically protects you saying, I'm sorry. We're not in the minority group, those 8 states that say, we'll protect you to say I'm sorry, and we'll also protect those lovely words of, I screwed up. I didn't know what happened. In other words, they protect the apology section and also protect the admission. One thing that I will tell you is that we have seen since 2005 more questions regarding what you can say and it be constituted an apology, and we saw that here. As the bill was originally introduced, you'll see on the bottom of that slide that it was going to also permit providers to give an explanation. Because again, if I had a patient up here, what would I tell you? I would tell you that that patient wants to know, yes, you're sorry, I appreciate that. Tell me what happened. Tell me it won't happen next week. And tell me what you've done to prevent it. So we're going to be working on that front. That was introduced, and the concern arose that we didn't want to create a false sense of security, because the trial lawyers didn't want to create a blanket allowing a situation like this. Something goes wrong in the operating room. Surgeon comes in and tells the family, I'm sorry, and here's what happened, and lays out all the facts of what went wrong. Later on, they did not want the defense attorney to jump up and say, whoop, the surgeon can't answer any questions about his explanation or about the facts surrounding that. The jury can never find out about that. So the plaintiff's attorney said one approach is to say whatever that provider tells that family member in the way of explanation, that might be protected. But if those are facts or include facts that are otherwise discoverable, that would be free game. Meaning when the deposition of the surgeon is taken and that surgeon gives an explanation then of what happened, that comes in. So you see the false sense of security. You have a surgeon telling a family an explanation thinking that that will never pop up again later on, only to have his deposition taken before trial and in fact that information come out and that information be discoverable. So the decision was made collaboratively to remove the protection for the explanation. That's still work to be done, and instead the underlying language you see up there was what was advanced. So where do we go now? What are our next steps as we move ahead? We still need to answer the call that we're hearing. A lot of physicians continue to say they want to be able to freely talk with their patients and tell them what happened. It's hardly a meeting of the Medical Society's Board of Directors that goes by that at least one physician does not inquire about this, advocate for this, promote it. It's very much an issue at hand. It's very much the challenge of that HJR 101 study that's going to take place this summer. How we do that is the struggle. It can't be too broad, it can't be too narrow, and it must be accurate. So I leave you with those questions. I certainly thank you for your time and for having me this morning, and we'll turn it back over to Joe.
Thank you very much, Scott, for that very informative presentation. Are there any questions for Scott? You know, a lot of what he said was probably provocative and thought-provoking, so we do have some time. If there are anyone who'd like to come forward with a question, please come up to one of the microphones and Scott will try and respond.
Scott, I'm Chal Nunn at Central Health, so I've worked with Dan Carey very closely, and we've been fairly aggressive with apology and disclosure. We've trained hundreds of individuals, including physicians, and we are well on our way in disclosing. What we've found as we get into it, it's easy for the clear-cut cases. We made a medication error, or perhaps we left an object in the abdomen, or perhaps we operated on the wrong body part. It's where you start getting into the details of things that should you disclose or should you not, and I guess I have to give you an example or two. For example, we would debate if we were 1 hour late in delivering Lovenox for DVT prophylaxis, should I disclose that to the patient that we were 1 hour late in doing what's by objective measures the right thing to do. Also had just a case this week to where we think one of our controlled bacterial cultures in our sterilization process was false positive. Became positive right at 48 hours. We were an hour late picking it up, so 5 patients potentially got exposed to instruments. We elected to tell them that this happened, and we explained why that was. I've also had a physician have a case to where a bacterial culture that he saw the day before, what he thought was a false positive, turned out the next day to probably be a real positive, was delayed 24 hours getting the patient the right antibiotic, and the patient had not as good of an outcome as a result. So you get into these very gray areas of sometimes when you disclose, you really don't know, and you don't know what real effect it had. And so we're starting to enter into those debates now, and I didn't know what your thoughts were about that.
Sure, I sort of borrow a rule that is we use at the General Assembly a fair bit, that don't say anything that you don't want repeated the next day in the Washington Post, and turn it just a little bit. Can you defend yourself to that Washington Post reporter the next day if you didn't tell them? I would submit to you, probably on your Lovenox patient, telling them we were an hour late, you didn't suffer any harm, but in full disclosure, that probably would build more trust and not raise many antennas. And I've always been one to err more on the side, I would rather tell you, because if that was my wife you were treating, I'd rather know.
Give Scott another round of applause for his presentation.